Hello, everybody. We're here with another edition of GYN Garage. I'm Ed Pavlik in Lexington, Kentucky, and my collaborator here is
Frank Lawton from London, UK.
Well, we're here today to look at two papers. The first paper is has to do with neoadjuvant chemotherapy. And Frank, why don't you launch on this paper while I bring it up?
Okay. Well, the first thing I've got to say is I think it's terribly cool to call it. I have skin in the game with neoadjuvant therapy because I was the lead author on the first paper that was ever published in the Green Journal in 1989 about the use of neoadjuvant chemotherapy in ovarian cancer. And since then, clearly, there's been, I think, probably 3-4 randomized trials and a vast amount of data looking at the pros and cons and the outcome, etc. And I think in general, I think the paper seems to suggest, well, there doesn't seem to be a therapeutic disadvantage to IDS, neoadjuvant chemotherapy, and it may be reduced toxicity, etc. These people have looked at a small subgroup of patients with ovarian cancer. Randomized trials have been essentially those looking at high-grade serous tumors, and the authors admit that in other studies, the non-high-grade serous ones have been probably less than 10% or so of the population. Although from Rose's data and Van der Berg's data, there seems to be actually a higher proportion of non-serous tumors. However, what they say is that there has been an increased use of neoadjuvant chemotherapy for the less common cancers, mucinous, clear cell, and low-grade serous. And in a way, this is a little bit like mission creep, isn't it? It's whenever a country or whatever starts some sort of skirmish that's local and whatever, you know, in time it's going to spread. And I think if IDS, neoadjuvant chemotherapy, has been shown to be useful, then almost inevitably physicians, clinicians, surgeons will use it willy-nilly. I think this paper is important because I think it does show that there isn't a one-size-fits-all, and that's what I'm pleased about, that if IDS, neoadjuvant chemotherapy, has a role, then I think papers like this are starting to show that it is not right for everybody. What they've said is the use of neoadjuvant chemotherapy has been increased slowly over the time of the study period for clear cell and low-grade serous tumors, but interestingly not statistically for mucinous tumors, presumably because the feeling is, or the data suggests, that mucinous tumors are less chemosensitive anyway. They looked at overall survival, and it shows that they're comparable for clear cell and mucinous tumors, regardless of whether the patient had neoadjuvant chemotherapy or not. But it seems to show that there is a survival disadvantage for patients with low-grade serous tumors. My arguments about this paper are the complete cytoreduction rates in both of the arms, or they're not arms, in both of the sides, are actually quite low. The neoadjuvant chemotherapy regimen only up to 67% optimal cytoreduction, which I think presumably in the United States, particularly, and in Europe, would be thought to be on the bottom end of what could be achieved by surgery. And even the primary surgery is between 67 and 75%. So I think the group of patients that they've looked at, probably neither side has actually had optimal cytoreduction, whether or not it's been upfront or secondary. They've not looked at the other, and perhaps it's because the tumors are rare, but they've not looked at anything at the other tumors, undifferentiated, the mixed ones, endometrioid tumors like that. And there's no data on the timing of surgery, how many cycles of chemotherapy the patients had before they had their surgery. No data on tumor burden before the surgery, either surgery began, patient's quality of life index, etc. And there's been no pathology review. And I think that's quite important because I think quite a high proportion of patients with mucinous tumors are actually found to have tumors of gastrointestinal origin rather than ovarian origin. So what does it show? Well, I think it shows that there seems to be a subgroup of patients who don't do well with neoadjuvant chemotherapy. One size doesn't fit all, and I think that's important, and I think it should be something that should be tried out with primary debulking as well, but that's a different problem. And I also wondered whether this would encourage people like Peter Rose and Sean Kehoe and Ignace Fagot, who've written or looked at the big study, the big randomized studies, to have a look at the data again and see whether or not within that huge group of patients there is an inferior outcome for the patients with the less common epithelial tumors. So I think it's important from that point of view, and I'm sure it'll engender a lot of work if people are sitting on a large database.
Yeah, I agree with you, Frank. I'd like to point out two things. Is that they use two cohorts, two big databases,
Yeah.
which in themselves have different characters. Maybe they were asked to do that by the reviewers, so they went back and did it. Nevertheless, the clear cell outcomes were not worse in the SEER database. And so that's something that, you have to notice, and it's striking. And then you have to ask, about why. Um, and one of the things is clear cells are by definition high grade. So they shouldn't have behaved in one of the databases like the low grade serous.
Yeah.
So that's that's sort of a mystery to me. What's going on there? It just could be on the difference of the databases. The key graph that you've been talking about and I've been talking about is this graph right here, which basically shows the difference between those people in the red line that were treated with surgery and chemotherapy, and those in the blue line that were treated with were pre-treated with neoadjuvant chemotherapy, and then received the surgery and chemotherapy afterwards. You have to ask the question if the line in blue for low-grade serous is so inferior, it must be due to something. And my guess is what it's due to is that the NACT, the neoadjuvant chemotherapy, isn't doing anything, but it's causing a delay to surgery and to chemotherapy. And I think that delay is what's causing the effect of on survival to be much lower in the low-grade serous ovarian carcinomas. That's sort of recapitulated in another graph here that basically is based upon hazard ratios. And they basically said that on the left side of this line, hazard ratios will be less than 1. And they're making their case even more. So my explanation for a lot of this is the delay that's caused by a treatment that, that doesn't work. I'd raise one other point, and that's that if I can show the slide where, got my fingers sort of goofed up here, but if I can get down here to, I'm still looking. Bear with me. We can look at this slide of A and B being low-grade serous ovarian carcinoma, and the slide C and D being high-grade at two different magnifications, C and D. We have to worry about what's in the middle. Of course, it's a blank space in this slide, but it's what used to be called moderately differentiated or type or grade 2s. Grade 2s now are reconciled by putting them in with grade 3s and calling them type 2 type of ovarian carcinomas. But it raises the question, if were there any type 2s in these databases, excuse me, were there any grade 2s in this database that contaminated the grade 1s and would account for poorer survival that way? So I'm not saying that there were, but it raises the question, because it'd be, if I were doing the experiment, it would be hard for me to know based upon, as Frank pointed out, the lack of a pathology review to
Yeah.
make sure that what we were looking at was exactly what we said they were looking at.
Yeah.
So I'd say that there's information here, and I think the cautionary tale is, as Frank pointed out, that automatically extending something that's effective with one type of the 5 types of ovarian cancers may not necessarily be extendable to other types, and especially the low grade.
Yes, I think the other thing, Ed, is the data on how much or how many cycles of chemotherapy before you undertake intervention surgery is important. There've been a lot of studies showing that probably 2 to 3 cycles is the optimum amount of tumor regression you're going to get before surgery. And there's no evidence, no data at all on this. And I know for a fact where I've worked that some people or some physicians have said, oh, let's just give some more chemotherapy because we can get a better response. And I think your point is, if you're dealing with a tumor that's essentially chemo resistant, it doesn't matter how much you throw at it, it's not going to reach a point where it's going to get so much smaller that it makes intervention surgery successful. And sadly, of course, that we don't know whether these patients were treated after 2 cycles or 4 cycles or whatever else. It's an interesting paper, and I suspect it will have influence on other reports on neoadjuvant chemotherapy, intervention surgery, looking at this pathology. But I think they've got to do it up front now, and there needs to be pathology review, central pathology review, I think.
Sure. The other point that just occurred to me by what you said is that we know that the low-grade serous ovarian carcinomas are slower growing. They're still deadly, but they give much more survival time. Does that translate? And this is an open question. Does this translate how neoadjuvant should be administered? And that would be for more cycles or for a longer period of time. And we don't know the answer.
No, we don't. No. And these studies, unfortunately, won't give an answer to that. But perhaps it's work for people in the future to incorporate this idea into when they randomize patients for whatever surgery. They should look more closely, perhaps, at these subdivisions of histology, because it appears to be important in this study anyway.
Exactly. Well, I want to go on to another paper here, and this paper has to do with an entirely different subject, and it has to do with adverse birth outcomes in women who are being treated with chemotherapy for cancer. So these are called adolescents and young adults, and their age range is from 15 to 39, which is where most people who have pregnancies are going to fall. Paper appeared in the journal of the JNCI and the National Cancer Institute's journal. And what we can say is that the preterm birth rates were higher in those women who had cancer and were treated for it, and there were lower birth weights in these women, in their children, in their offspring. So that would be expected. If you have babies born sooner, you'd expect them to be smaller. But what they did find also, which is positive, the birth rates were not different in these women being treated for cancer. All this really should cause some pause in women who are going to have cancer and going to be treated, so that they know that there's a possible effect. They should be near a NICU unit. And the long and the short of it is that the considerations to be made are, there was nothing about chemotherapy in this paper. There was a type, the dose, the number of cycles, and there was no information upon miscarriages. Now, these were not cancers just limited to gynecologic malignancies. These were cancers across the board, including lung cancer, melanoma, so that really we're looking at the net effect of on anybody with any cancer who's carrying a baby. Frank, what do you think?
Yes, the first thing is that I think if I were a 39-year-old, I'd like to be called a young woman as well. The average, in the UK, well, I'll tell you, in the USA, the average age of first conception is 26.9 years, so 10 years younger than the cohort that they're dealing with here. However, that's beside the point. I don't know. Well, nearly 50% of these patients are from ethnic minorities. And we know certainly from the UK, and I'm sure it's the same from the USA, that patients who are pregnant from an ethnic minority have a poorer pregnancy outcome anyway, regardless of whether or not they have a cancer at the same time. Two interesting things. Well, the first one is that the median gestational age at diagnosis was 22 weeks. Which seems to suggest to me that the antenatal care these patients were getting was not very good. I mean, to diagnose a breast cancer, presumably at 22 weeks, means that the patient either didn't have antenatal care up to 22 weeks before she presented with a breast lump, or didn't tell the attending physicians or midwives, or the attending physicians or midwives ignored it. It just seems to make a diagnosis nearly halfway through the second trimester that a woman has cancer does seem rather strange. And the other data, 40% were diagnosed in the second trimester and 36% in the third trimester. So these women were nearly at term, or certainly with more than 30 weeks before their diagnosis of a cancer was made. And as you say, it's not all gynecological cancers, which I think is important. And we do know that some cancers, I think breast and melanoma, do have a worse prognosis for pregnant women. What we don't know, of course, is these group of women, they had preterm deliveries, but was that because they had an induction of labor because of the cancer, or did they go into a spontaneous labor? We don't know anything about their past history. For instance, women with gynecological cancers or precancers, had they had CIN and a cone biopsy? Was there some sort of cervical incompetence, which is why they went into labor earlier? We don't know any of the other factors within a pregnant woman that can affect outcome, such as hypertension and comorbidities. And the other thing which I think the authors do mention is that, and I don't know when this happened, but abortion in Texas, where these data were collected, is illegal. And so for any reason, which includes whether or not patients need urgent treatment for a non-obstetric complaint, they do mention the fact that some of these women who would probably, if they could afford it, would seek treatment outside of Texas, possibly an abortion, weren't able to afford it. So I think the data looks interesting, but there's an awful lot of comorbidities and co-problems with this that this really just cannot assess. We know that women with cancer in pregnancy do less well. I'm not sure this actually tells us anything more that we already know.
Yeah, I agree. I think for the woman who says, well, I don't really know what to decide, I think one thing to decide is that the danger of birth defects doesn't seem to be erased by this paper.
Yeah.
And that in a sense, I think except for having a low birth weight baby and having that baby earlier, we shouldn't have a woman thinking about delaying treatment for her malignancy in her concern about her offspring.
Yes.
So those things are there. Well, we've done it again, Frank. So for better or for worse, for harm or no harm,
yeah,
we finished off another Gynec Garage. So I look to see you again.
Yeah.
And
You take care.
You take care.